Don't get caught in the mosh pit. Fuel to the fire, ain't nobody can stop it. Trouble in my city, but you know I'm across it. Got a 40 on my hip and I'm liable to spark it. Throw down these hits, my click is indivisible. I aim, you duck, I squeeze, now you invisible. I'm not afraid of getting physical. All these different chemicals are fogging up my visuals. Bloods on my hands, got slugs on my gunners. Yo, we notorious, we ain't no runners. Bloods on my hands, got slugs on my gunners. Yo, we some warriors, they ain't no gunners. Bloods on my hands, got slugs on my gunners. Bloods on my hands, got slugs on my gunners. Put on my sweat, put on the beat, put on the map, put on my team. Take out every motherfucker in between. Know what I mean? Better myself, better my aim, better my rep, better my name. Killing rappers on my hang, I'm running chains for the fame. Never thought I would it, now I'm running. You don't wanna follow me, now I'm fucking funny.
Good evening, and welcome to a special broadcast of Steve the Kidney Nurse on Urban Health Outreach Media. I am your host, Steve Belcher. Today, we have a special broadcast, the dialysis crisis in Kenya. We will be discussing proposed cuts in dialysis treatment by the NHIF, which stands for the National Hospital Insurance Fund. It's somewhat like the Medicare here in the U.S. The NHIF, which was founded in 1966, is a Kenya government state corporation with a mandate to provide health insurance to Kenyans. The core business and mandate for NHIF is to provide accessible, affordable, sustainable, and quality health insurance for all Kenyan citizens. Currently, the NHIF has suspended the decision to reduce reimbursement from 9,500 shillings to 6,500 until the end of the year. Today, to help discuss this terrible issue that's going on, I have with me the kidney ambassador, Moses Kennedy, as my co-host. Also joining us is Dr. Julius O'Keel, nephrologist at Aga Khan Hospital, and also joining us, which we're having some technical difficulties at the moment, is Mr. John Kikonya, president of the Renal Patient Society in Kenya. So let me bring on my co-host, Moses Kennedy. Let me give him the VIP treatment. Hey, Moses, how you doing?
I'm great, Steve. How is the US?
Pretty good, pretty good. Welcome back, man.
Okay.
It seemed like now you're back under a different topic and pressing matter. So before we get into this topic, let me bring on Dr. O'Keel, okay? All right. Let me give him a special guest welcome. Hi, Dr. O'Keel. How are you, sir?
All right. How are you?
Pretty good.
Hello,
pretty
can you hear
good. Me? Yes, sir.
Yeah.
Thank you for taking the time out of your busy schedule to join this broadcast this evening. I know it's around 8 p.m. East Africa time, and I'm sure you had a long, busy day. So again, thank you for taking the time out of your schedule.
You're welcome. Thank you. Thank you for inviting me in this broadcast. Yeah.
So, Moses, let's talk about these drastic or proposed changes by the NHIF. One is to reduce reimbursement for dialysis sessions from 9,500 shillings to 65 shillings. Talk about that. How would that affect treatment in Kenya?
Thank you so much, Steve. Dr. Kell, we are proud of you for having joined this session. Thank you so much. Now, a crisis is looming here in Kenya. The proposed NHIF changes may affect dialysis patient in a manner that we are not going to have damage control. I know if these changes goes through, then the entire dialysis, the entire renal treatment in the country might collapse. Maybe I'm not going to speak much because let's hear from a renal specialist, Dr. Kell. May I just welcome him? Karibu sana, Dr. Kell.
Thank you, Moses. So I'll just briefly give a background, and then just paint the picture of what the problem would be like. So
sorry about that. Doc, can you
kidney HIV?
There you go.
I was just trying to give a background that the kidney program, the dialysis program in Kenya, as is supported by the NHIF, is just about 7 years old. Prior to this, hello, can you get me?
Yes, sir. We can hear you.
Yes.
Yeah.
Yes, sir.
So I was just saying this program is hardly about 7 years old, and prior to the NHIF coming on board to support kidney clients in Kenya, the diagnosis of end-stage kidney disease, that's the advanced form of kidney failure, was more or less like a death sentence. When I returned from Canada, where I trained actually, I faced the crisis right on. A patient would walk in my office, of course we'll do the lab test, and then bang, the news would come that they have renal failure, and the family would not know what to do because the dialysis program was prohibitively expensive. A patient would come in and dialyze once, twice, and then would run into a financial crisis, really, and would go on selling the items one after the other, and it wouldn't take long. It wouldn't take long. Basically, between 2 to 3 weeks, they would start missing dialysis, and by the end of the first month, they would not afford it and miss it more, and they would die either from pulmonary edema or hyperkalemia. It was really a sad story. By that time, there were hardly about 500 patients dialyzing in the whole country. And we're not many colleagues. We're just about 28 nephrologists covering the whole country. So we knew this. So out of lobbying and some political decision, addition was made for the government to support the dialysis program. And it was really a game changer. Within 4 or 5 years, we moved from having just about 500 patients doing dialysis in the whole country to the current number, which is about 6,000 patients doing dialysis in the whole country. Part of that increased prevalence was that we were able to take care of these patients better, and they're actually living longer, hence the high prevalence of these patients that we're seeing currently. So when we got the news that the NHIF was proposing to cut down the reimbursement they're actually giving, it was really disheartening. Because with that decision, this program will basically collapse, in the sense that the majority of patients who undergo dialysis are not able to afford out-of-pocket expenditure to support their dialysis program. Because what the program proposes to do is really to increase the number of sessions offered from twice a week to 3 times a week, but cut the reimbursement by just majority of patients would have to dig into their pockets to pay for their dialysis programs, and predictably, majority will not be able to afford and will drop out of the program and have complications of inadequate dialysis and probably, unfortunately, pass on in a few weeks' time.
Now, Dr. O'Carroll, you mentioned that one of the proposed recommendations by the NHIF is to increase the number of dialysis sessions from twice a week to 3 times a week, correct?
Yes, that's true.
And that's going to require, according to an article I seen in the paper from Kenya, an extra $9,000 or 9,000 shillings every week to top up the NHIF paid fee.
That's accurate. So that's almost 28,000 Kenyan shillings per month.
And how much is that, if you know, in US dollars?
So that's roughly about 28,000. That's about 280 US dollars.
280.
Yes.
Wow. When that's not much here. I mean, Medicare reimbursement here, I believe, is around 256 per treatment. Don't quote me on that, but that's through the government. And as you know, we have private clinics here, which are Fortune 500, a lot of them, DaVita, Fresenius. And so they're able to actually do mass production and able to be more cheaper, where they dialyze a lot of patients under one roof. Is that the same there in Kenya? I noticed that there are approximately 54 public dialysis centers serving 25% of the patient. And then you got 142 private centers that cater to the 66% of patients. And then there's about 17 faith-based centers that cater to the remaining 7.9%. Is that a disparity there with when you come to 54 public dialysis centers over 142? Why is there a disparity in number?
So the public dialysis units have about, I think you're probably right, about 30% of the dialysis patients, and the private sector, including the faith-based, just serves about 70% of the patients. The disparity has come about because of some of the inefficiencies that clients tend to see in the public health dialysis units, because most of them don't run all year round. They would run, for example, 3 months, 4 months, close down for one case or another. Maybe dialysis consumables have run out, or the water plant is not working and they have to do some form of tendering for public health system. Tendering is quite tedious. So there've been a bit of inefficiencies and closing up and down. So hence the coming up of private dialysis units that serve almost about 70% of the patients. But in Kenya, whether private or public, the rate is capped. The reimbursement is the same. It's about, initially it was about $9.5 per dialysis session, whether public or private.
Okay. Moses, do you attend a public or a private facility?
I attend a private facility.
Okay, I think we may have Mr. Kikonyo on. Hello, sir, can you hear me? Okay, we still having some internet
Mr.
connection.
Kikonyo.
He's unable to, I'm not able to hear him, Moses.
Yes.
So,
hello,
okay.
Mr. Kikonyo. Okay.
Yeah. So Doc, let me ask you, they're thinking about reusing the dialysis filters like they do in India. We know here in the US that was tried years ago, and now they have stopped the reuse program. In your opinion, do you think that's medically beneficial for patients to undergo reuse of the filters?
Hello?
Yes.
Yes. Can you hear us, Dr. Ari?
Yeah, if I get it right, you're asking.
I'm sorry, sir. We lost the connection with you.
Oh, Steve.
Hello?
Maybe
yes,
you can ask again. Yes.
Hello?
Perhaps
can you hear me?
You can ask once again.
Yes, sir.
Yes, I can hear you.
Okay, Dr.
Hello?
Kell, can you hear me?
Hello?
Yes.
Yes, Dr. Ari,
yeah.
We can
so
hear
I'll
you.
just, if I got you right, you're asking about the reusing of the dialysis in treating the kidney clients in dialysis?
Yes, sir.
Yeah,
Absolutely.
that is actually accurate. So there is a proposed private investors who are selling to the NHIF the idea of reusing the dialyzers in trying to cut down the costs, and therefore bring it down to just about the 6,000 or $6 per session that they're proposing.
Okay.
Of course, as a community of kidney doctors, we've opposed that, because even in the countries that it was tried, for example, in India, there were a lot of complications that occurred, including bacterial infections, hepatitis B infections, and it was just chaotic. And in Kenya, as we know it, I mean, there's still a lot of challenges in terms of infection control. And if that is to be permitted, especially in the public sector, it will be catastrophic, really, in terms of the morbidity and the infection spread, especially those transmissible by bloodstream infections. It will be really catastrophic, because we feel they don't have the capacity even to try thinking of sterilizing the dialyzers in the public sector, and even in the private sector. We really cannot go that road now.
Okay. Now, doctor, let me ask you. There are numbers that says that I guess, don't quote me, that the cost of a transplant in Kenya is about 8,000 shillings. Is that correct, or is that number a little low?
That's low. So the cost of a kidney transplant, if you do all the costing, would be about 1 million Kenyan shillings to 1.5 million Kenyan shillings. That's about $10,000 to $15,000.
Wow.
Per transplant.
Wow.
And that is the surgery and the initial medication.
Opposed to here in the U.S., something like that would be over 100,000, maybe up close to $1 million.
Yeah, it's about $10,000 to $15,000, and then the post-transplant follow-up, including the drugs, unfortunately, are not covered by the NHIF. Patients have to pay out of pocket, and part of the thing we're trying to really talk to the NHIF about is make it easier for us as kidney doctors to transition our patients from dialysis and have them have successful kidney transplant, which is not only superior in terms of outcomes, but also cheaper in the long run. In modeling in many countries, transplantation is actually cheaper by the second, third year.
Mm-hmm. Well, we had Moses on, and Moses had mentioned to us that in order to get a transplant in Kenya, it has to be from a relative.
That's actually true. So the program we have in Kenya is strictly living related donor kind of program. We don't do deceased donor because we don't have the infrastructure to have a quick harvesting of a kidney and ship it around. The law was passed to ensure just related donors to avoid the issues of trafficking of kidney and buying of kidney. So it was put that way so that we avoid that program. But unfortunately, it has limited the program in terms of just having it requiring a donor to be within a family. And of course, we know some of the kidney diseases tend to have genetic predisposition, and therefore a relative will be more predisposed to having the similar disease that's causing the patient to go into renal failure. So recurrence and all that is actually higher if you limit this just within family in terms of donation. So it's a law that we are discussing with NHI, with the Ministry of Health here, which is the custodian of the laws governing the health practice in Kenya. But that's what we have. We have living related donor program. We don't have deceased donor program.
Okay. Moses, what do you got to say about what's going on today with the news of the NHIF kind of curbing the putting a hold on this decision until the end of the year, until they talk to the stakeholders? What are your thoughts on that?
Thank you so much, Steve. Thank you so much. The truth is, there is a looming crisis in Kenya on renal treatment. In fact, I just want to take Daktari back to the proposed changes, because Daktari will now speak on behalf of us as an expert. Away from dialysis, there are other also expenses that comes along with treating a kidney condition. Amongst proposed changes, we also have other faculties like surgeries and diagnosis tests like MRI and CT scan. There are also some cuts. Maybe Daktari can also shed some light on that, so that we get to know the impact of reducing the same.
So really, the cuts across most of the aspects of care, not only just renal, but also other diagnostic setup. So they propose also to cut, initially NHIF would reimburse a small cost of the kidney transplantation cost initially. Initially, they would, I say the cost would be between $10,000 $15,000. So they'll give about $3,000 to $5,000 per transplant. They propose to cut that down to about $1,200 and between $1,000 and $1,500 per transplant. The second thing they've done in terms of procedures, before a patient can go through dialysis, we do procedures of placing catheters, for example, permanent catheters. Initially, they would reimburse that about 30,000 Kenyan shillings. That's about $30,000, about $300. They've cut that down to about $150. That's about 15,000, basically by half. The MRIs and CT scan, they've not only made it difficult in terms of access, but also have that cut. I don't have the exact figures, but they also cuts to that. So essentially what you are telling the kidney client, not only is your treatment cut in terms of the reimbursement per session, but if you are to seek other diagnostic tests, including MRI, CT scan, laboratory tests, they will not be supported. So it's really a cut across the board, not only for the treatment of dialysis, but also other diagnostic setup. So if a kidney clients were to fall sick, say they have, God forbid, a stroke or anything like that, accessing the standard care would be not only costly, but more difficult for them.
Wow.
If NHIF actualizes the plan.
Okay. Doc, let me ask you something. So you said medications are not included in that payment scheme, correct? When it comes to reimbursement, it's only reimbursed.
No, it's not included. So every client undergoing dialysis, they have other problems that we usually have to manage, including low blood levels.
And
so every week, so every week or every 2 weeks, we give them hormone boosters and iron to boost the blood. That's not covered by the NHIF.
That's what I was going to ask you. The anemia medication, like here in the U.S., is called Epogen or Airnest. Or say if the patient iron stores are low and they may need Felicit or some iron replacement. You're saying that these medicines are not included in reimbursement. So if the patient hematocrit or iron levels fall low and they're not able to come out of the pocket to pay for that, what happens?
They basically have to pay through they have to pay out of pocket. If they don't have that, then
I mean, pretty much, is it pretty much tough luck?
Yeah, they have to pay it out of pocket.
But if they don't have it, then they pretty much suffer in a sense.
Exactly, they suffer. They have heart failure. They can't move around.
Now, Doc, let me ask you this. One of the changes, and I just want to figure out the difference. One of the in the new scheme, NHIF will categorize units into comprehensive and non-comprehensive Explain that, because they say in the comprehensive category, patients will not be expected to pay additional fees to top up for their hemodialysis session. And in the non-comprehensive category, patients will top up for their sessions. What determines what category the patient goes into?
So they basically classified the hospitals. So like the public hospitals would be the comprehensive category. So patients going for dialysis in the public hospital, they may not be required to top up for their dialysis. But really, the dialysis in the public sector can only accommodate 30% of our patients in the current scenario. In the current scenario, patient dialyzes about twice a week. If you increase that to 3 times a week, that already almost puts the pressure further by about 30% of capacity needed. And the public sector, even now, just can accommodate 30%. So you have 30% of patients, even if they would wish to go to the public sector, they won't be able to. That's one. Secondly, if they were to go to the public sector, we know that there's a bit of inefficiency and erratic delivery of service there. They will be closed more or less on and off, and that will affect patient care. So the non-comprehensive category is the private units, the 70% of the remaining units, where patients will be required to top up for the dialysis session.
Mm-hmm. Mm-hmm. Now,
okay, Daktari.
Okay, go ahead, Moses.
Daktari, maybe because you've talked of, you've tried to shed some picture how the crisis gonna be at the public hospital. Maybe if we can get more insight how it will affect the patient directly, because we know before private hospitals were engaged by the government, there were basically shortage in everything, from staff to consumable, you just name it.
So the first thing that would happen is lack of capacity. So, I mean, if you have this 70% of patients trying to cram up in the public sector, you'll have a situation whereby a patient will wake up as early as 3 a.m. or 2 a.m. to go and queue to be the first person to get dialysis. Of course, invariably, some of them would end up missing the sessions and getting under-dialyzed, and that, of course, will cause complications that we know if somebody doesn't get adequate dialysis. Secondly, the staffing capacity in public sector, although there's a bit of effort, is really it's not up to date. In terms of the nursing care, the struggle. Many public hospitals offer dialysis just 4 times a week. That is Monday, Tuesday, and Thursday, Friday, because of lack of staffing. In addition, in terms of nephrology attendance, most centers, only a few county hospitals have attendance with a nephrologist.
Hey, Doc.
Hello.
Yes, if I could chime in.
What of the?
No, I'm sorry, Moses. I just wanted to chime in about that staffing shortage. In the article, it says that Kenya has 44 nephrologists and 600 renal nurses serving about, like you said, about 6,000 patients. Doc, how can that number be risen up to increase more staffing of renal professionals?
So the World Bank did fund a regional training center for East Africa, actually, which is a good thing. We have a regional training center for Rwanda, Burundi, Kenya, and Tanzania in Nairobi, and that's a good thing. We have had some nurses getting trained and a few nephrologists getting trained, almost about 2 to 3 per year, which is a good thing. The challenge has been in terms of funding. Most of the county hospital, which is responsible for healthcare delivery in the particular counties, have not been hiring enough nurses and not even nephrologists to take care of these particular centers. In fact, some of the nurses that have been trained locally have found their way into the US, UK, and other countries. Yet we have a large shortage of that kind of staff in our hospitals.
Okay. I'm sorry, Moses, was you going to say something?
Yes, actually, Dr. has just answered it. I also just have one more query to Dr. That now that, as we speak, what is the state of these proposed changes at NHF?
Hello. So they did propose to engage other stakeholders. So today we had the Kenya Renal Association that I belong to having a meeting with NHIF, which went on for about 5 hours, but there was no particular agreement in terms of the way forward. And they proposed to have a smaller team, where the Kenya Renal Association will propose some number of professionals, and they'll propose some number of staff to meet again and try hold further discussion. But what's coming on from out of the meeting is they did state that they're running short of funds, and then they want to rationalize their upcoming budget to be able to cover the whole of their mandate. And it may seem that part of the thing that they would cut to try save on some of the cost is the renal dialysis.
Doc, let me ask you, in your opinion, and if this is a growing problem in Kenya, why is it that the cuts are going against kidney dialysis treatment and maybe not cuts that maybe not life changing to people there?
So I didn't get your question clearly. If you could just come on again.
I'm sorry. My question is, why is the NHIF, why are they proposing cuts for people on dialysis when they know this is a much needed treatment and know the advancements of them paying for this treatment has been beneficial from the past, people not having to sell their property or borrow money? Why are they almost seem like they're going back in time?
That's a question we've been asking ourselves as health professionals. Actually, we didn't actually understand it, why they would do something like that. But I think part of the problem, the staffing there really don't understand what their decision, the implication of their decision. So part of the aims of our meeting today was just to try paint a picture of what their decision would look like. To an extent, it seems like they're starting to get what it means, what the decision would mean. But again, they didn't really come out to say that they'll try to source for funds or try to lobby around to get funds to fund it. They still want to go down to the costing and try as much as possible to push the cost down. But it really baffles most of us who have seen it right on the face. And we bet any of them, if they had a brother, sister, or mom or dad who was undergoing dialysis, they would actually not make that decision.
Yes. Let me ask Moses. I don't know the laws in Kenya, but are patients allowed to like go down to the NHIF and what's the word I want to use? Like picket or pretty much complain that this is happening to try to really stop this?
Well, I'm not really conversant with the law regarding that, but I know as a patient, we can also just do some little contribution. Yes. But maybe I will request Dr. Kell to see maybe what can happen if at all.
So legally speaking, the Kenyan constitution actually guarantees health to the extent that the government can fund it. And dialysis provision, it's a matter of life and death situation. And really, it's a human right to actually access it. So we've actually engaged patients and tried to educate them and empower them, more than just picket, which is the right, really. We actually have encouraged them to seek legal redress in courts. Kenyan courts would recognize that as a denial of the right. And they had a legitimate expectation, just like they had dialysis the previous 5-10 years, to ask of the government and NHIF, for that matter, to continue funding the program. And given the magnitude and the impact that decision would create, we know for sure, if well presented, the courts of law would listen to them.
Mm-hmm. Yes. I think we had Mr. Kikonya. I'm not sure if we can hear, but he's here, right here. So I'm sorry, go ahead, Moses.
Now, Daktari, are we able to, as a patient, are we able to have other option other than picketing? Because sometimes
that's what I just mentioned, that through Mr. Gikonyo, who I'm hoping will come on,
yes.
We hope that if this actually fails, then you'd actually seek legal redress in a court of law to compel NHIF to cover this much needed treatment for you as kidney patients. And it's actually your right to actually have that treatment, because you pay a lot of taxes to this government and you deserve that life-saving treatment.
Mm-hmm. Mm. All right. We got some comments. Let me go to the comments and get your thoughts, Moses, and Dr. O'Kell's thoughts on some of these comments. Andrew mentioned NHIF is funded by the taxpayers. It should be accessible to all without discrimination. The government should be improving on this package for kidney patients rather than thinking of reducing the allocation. What do you think about that, Doc?
I agree. I totally agree. In fact, just about 2 months ago, the NHIF lobbied the parliamentarians, the lawmakers, to increase their base for collection of rebates from the population. In fact, a law was passed requiring every Kenyan above the age of 18 to actually start funding them. So I totally agree with him that with that base of funding increasing, they should actually increase the coverage, not only maintain it, but also cover the drugs and improve their transplant coverage to really, improve the quality of life and longevity of this particular patient. They should not be cutting back. It doesn't make sense to increase your base of contributions and then cut down or cut back on the very services that you're trying to fund by increasing the base of your contributions.
We have another comment by Anyanga Riaga. If I pronounced your name wrong, I'm sorry, but she says NHIF should not be managed as a private property, given that it's funded by Kenyans. Kenyans must be involved in every decision making. It doesn't make sense contributing to NHIF at the same time participating in fundraisers to raise money to pay health bills. This move by NHIF should not be allowed. We will resist to the end. Kidney patients are also Kenyans, and it's not a crime. And it's not a crime, I guess, to be sick. What do you think about that, Moses?
Come on.
Moses?
Yes. I think there is a mess at NHIF because the reimbursement is the same, 9.5 $9.5. And then vis-a-vis the service given, they are two worlds apart. This is also what baffles me a lot as an individual. Daktari, is there a way that we can also approach this? Because the reimbursement is the same, but the service, you wouldn't compare services from public hospital to private hospitals. They are two worlds apart.
Yeah, so I'll just address the comment that you read previously concerning the NHIF. I totally agree with those sentiments that it should not be like a private members club. It's a public entity. And decision like that touching on the population needs public participation. And the person who needs to be involved the most is actually the patient. The patient is at the core of that decision making. They should always try to get the view of the patient. As a healthcare professional, I'm not even the key in that decision making. They should involve the patient and really talk to them and ask them what their feeling about that decision is before they go ahead and effect it. And part of the reason the patients have a good enough reason to seek legal redress is lack of involvement of the patient in the decision at all. It was a boardroom decision, no involvement of patients in it.
Wow. So joining us, we have Mr. John Kikonya. Can you hear me, sir?
Yes, I can hear you, and I hope you can hear me too.
Oh, absolutely. Thank you. Thank you so much. I'm glad we were able to get the situation straightened out. Welcome to the broadcast.
Thank you.
Tell us, Moses mentioned that you was in meetings all day. What's going on with the NHIF that you recently learned?
Okay, yes, as you put it right, I was in a stakeholders meeting with NHIF today, and which I attended as the patient representative. And we wanted to get it from the NHIF themselves, what exactly it is they are proposing and how they have arrived at the figures which they are floating around as the figures they would be using going forward. And it was clear from the outset that there was no evidence-based basis for the proposals that they were putting forward. It was also clear that some of the aspects of that proposal have not been clearly defined or thought out. For example, you had the Daktari asking about the extra capacity of the third session, which I also queried the NHIF, and it appeared they had not really paid much thought to that. So we resolved that the whole idea should be shelved, and we came up with a task force which will meet, I think, from tomorrow, and within a week we sit down and go through the costing honestly and openly and arrive at a figure that makes sense, and also arrive at a situation that accommodates everybody, including the comfort of the patient. I did also raise up the idea of, just trying to put a kidney patient on 3 days of dialysis in a week, because that functionally makes someone a person who is just living to do dialysis. If we can still have quality 2 sessions of dialysis, a lot of patients would prefer that, because that gives them time to live as normal people, as opposed to where you have 3 days in a week where you are grounded for dialysis. So everything is on hold as we carry on with discussions for the way forward.
Doctor, thank you, sir. Dr. O'Kell, let me just talk about what Mr. Kikonya just said. He said something very important, and he mentioned that the increase in sessions, that patients will want to get the same, try to get the same results in the 2-session treatment. But here in the United States and a lot of other places, patients go 3 times a week, anywhere from 3 hours to 5 hours. And we know more treatment, better quality outcome. So how can you get, if you go 3 times a week and say you're 4 hours and that's 12 hours of treatment, or you go 3 hours and that's 9 hours, and you do 2 hours, 2 sessions a week and that's 8, isn't 9 hours better than 8? Can you just elaborate on that just a little bit?
So that's true. So the longer the sessions of, the more treatment you have, the better for you. And that has been shown in various experiments.
Okay,
many places.
I think the doctor is having some network issues. But
hello, can you get me now?
If I can respond to that, yes, it would be preferable to have up to 15
I can hear the
hours.
doctor.
Oh, sorry, I can't hear him.
Oh, sorry about that. Can you hear me now, Mr. Gikonyo?
Can I proceed?
No, the doctor, he's speaking. He asking if you can hear him.
No, I can't hear him.
Oh.
Wait a minute. Let the doctor speak, and then I'll let you know when he's finished.
Okay.
So I was just saying that, of course, more hours on dialysis, the better. In fact, in other countries where they do nocturnal dialysis, where you basically do 8 hours, it's even better. So in Kenya, when the program was actually rolled out, we kind of, for some patients, got away with doing twice a week dialysis for 4 hours, because most of these patients were young. You'll be surprised the average age of a Kenyan patient on dialysis is hardly 36, 30 years. They're young patients, and they have most of them are pretty good residual kidney function. So they can do relatively well with twice a week dialysis. But we know some of these patients, after a few years on dialysis, 2-3 years, lose that kidney function, residual kidney function, and they have to do now longer sessions of dialysis, say 3 times a week, or even 4 times a week if needed be. But really, the reason why most Kenyan patients got away with twice a week dialysis is because, one, they're young, and secondly, many of them had residual kidney function. But we know in our clinics, many of our patients still need that 3rd session of dialysis. And I think when we talk to the NHIF, we actually let them know that it is true, many of our patients require 3 times a week dialysis, but we could decide that for them. We know our patients, we examine them daily. We'll let them know that so-and-so needs 3 times a week dialysis, so-and-so needs extra dialysis, and that would be better utilization of the resources that you're actually scrambling to cover everybody.
Okay, Mr. Kikonya, you can go ahead. What was your input on that?
Yes, I was saying that a patient would not mind quality time on dialysis, and up to 15 hours would be appropriate and would have better outcomes. What we are saying is that it should be, or it should come with consideration for our life, our quality of life and comfort. So, for example, if I was to be on dialysis for 3 days in a week, then I would be losing a lot of time for my work and social life. And so consideration should be put for something like after hours dialysis, night dialysis, or even peritoneal dialysis that I can do at home. So these are things that NHIF has not considered. You have asked a question about the proposal for comprehensive and non-comprehensive. And for comprehensive, everything will be paid for. And non-comprehensive, you go there and pay out of pocket some portion of the cost of dialysis. What they don't seem to realize is that less than 500 patients of the 5,200 who are on dialysis currently would afford for non-comprehensive. Still, all the patient would go for comprehensive. The only difference would be that 3/4 of the dialysis service providers would now be under non-comprehensive. So we will have taken 3/4 of the patient population to 1/4 of the facilities. And, these are things they had not really thought out. And You could see it in their faces when we were talking today. So it is important that we have this kind of dialogue so that we have all these exchange, which is something they accepted and acknowledged. And we have proposed that going forward, we should have conversations before such drastic changes are made. The Kenya Renal Association gracefully offered their expertise free of charge to the NHIF panel whenever they are grappling with anything to do with kidney disease or renal issues. So we hope this is a beginning of cooperation of between all the stakeholders and NHIF going forward.
Dr. O'Carroll, does the NHIF have any initiative to reduce chronic kidney disease in Kenya, like any initiatives to curb this disease as far as education and awareness?
Zero.
Oh, thank you, Mr. Kikanya. So
you're asking whether there is NHIF reimbursement or support for preventive nephrology, that is prevention of kidney disease?
Oh, no, I was asking if they had any initiatives for kidney disease awareness throughout the country to help reduce the rates.
I get you. I think it's the same thing, really. They don't. And that's the problem we have here. Because more than anybody else in the world, the third world like Kenya needs to invest in preventive nephrology in terms of creating the awareness, encouraging the population to go and check themselves out so that anybody who's developing kidney disease is treated early, and that prevents them progressing to dialysis treatment or requiring dialysis treatment, which is a very expensive treatment. I mean, dialysis treatment is expensive for even the most developed countries in the world. It consumes a lot of resources. So NHIF, part of what Kenya Renal Association was aiming to educate them about is to prioritize transplantation, which is cheaper, and also in their program and activity incorporate preventive nephrology, which is creating awareness in the population, identifying the risk factors, optimizing the risk factor management so that these patients don't progress to require dialysis.
Okay. Moses, you had anything you want to add?
Well, thank you so much, Dikonya, for showing up.
Can I add something to
welcome.
that?
Okay, go ahead.
Mr. Sure, Dikonya. Go ahead, Mr. Kakanya.
Sure.
Okay, now this so-called crisis has been brought about by projections by NHIF that by the year 2025 we may have about 17,000 dialysis patients. And this projection is based on the expanded mandate of NHIF, which now includes the provision and the rollout of the universal health coverage. So they project that when we roll out universal health coverage, where we propose to support about 1 million households to come onto the mainstream health service programs, we are going to have a larger number of people who will now access health services, and from the diagnosis and the treatments they will get, we will have more people loading onto the dialysis program, which I have no quarrel with, and that is a possibility. But what now NHIF proposal for that then is to reduce the amount of money they are spending per session. But what we told them is that that projection should not just necessarily translate into dialysis. We do not necessarily have to wait until the 17,000 cases progress to renal failure. We can prevent some of those cases in best case scenario. Worst case scenario, we can delay some of those cases. And I give my own example where I was diagnosed with chronic kidney disease, and I was treated and managed in a manner that I was able to do a preemptive transplant, that is transplant before having to do dialysis. And therefore, I avoided dialysis for the better part of the time, the 6 years that I was dealing with chronic kidney disease. So not all cases that, or not all people who have the risk factors for kidney disease necessarily need to progress to that. But that would only work if we are working on prevention and control of non-communicable diseases in the country, because we know very well that the risk factors for kidney failure are in people with hypertension, people with diabetes. And so if we can be able to identify these people, treat them and manage them well and in good time, then we do not have really to be afraid of 17,000 people coming on to dialysis in the next 3 years. That should not be the case. So we should not just look at reducing the cost of dialysis. We should also look at preventing people from requiring dialysis. Another area we pointed out is that there's a host of tax regimes for some of the consumables used in dialysis procedures. For example, a dialyzer is taxed up to 30%, and NHIF has not even attempted to petition the tax authorities to suspend or repeal these taxes, because it's NHIF who is paying for this. And when you consider that this is being done for a one-use item, then it becomes a very costly component, expensive component of the whole cost of dialysis. So we did point out to NHIF that there are very many areas where they can look at reducing costs without punishing their partners, the service providers, or the patients. And also, we do not, like I said, we don't have to wait until somebody needs dialysis and we start struggling with the cost. We can delay, we can prevent end-stage renal disease from happening. So we hope these are some of the things we will be now fine-tuning with the task force that we'll be going on with. Thank you.
Awesome, awesome. Moses, was you going to say something before we wind down the show? Moses, can you hear me? Okay, looks like we lost Moses for a moment. Dr. O'Kell, before we end the broadcast, what should Kenyans know that dealing with this situation now, being in limbo with the NHIF? What can you assure them about, their treatment, or just staying healthy, being on dialysis, worrying about the outcome of a decision that can have a very drastic impact on their life?
So for the Kenyans who are on dialysis, I would probably inform them actually that dialysis provision by the Kenyan government, as per the Kenyan constitution, is actually their right now. They should demand of the government to fund their treatment because they can afford. We know that there's a lot of wastage in and within the NHIF in terms of inefficiencies and fraud. So the Kenyan client or the Kenyan patients on dialysis, we encourage them to stay vigilant, to wait for the task force that has been formed between NHIF and the Kenya Renal Association and other stakeholders, including the Kenya Renal Patient Association. And we see how much these negotiations will yield. But really, cutting down on the reimbursement for dialysis should be the last option for NHIF to do. And as Mr. Gikonyo had said, there are other avenues that should explore before they embark on this this venture in terms of cutting down on the reimbursement for dialysis.
Wow. Okay. Thank you, sir. How about you, Mr. Kikanya? What can you leave with the many Kenyans maybe watching this broadcast and other people affected by the NHIF's decision, what words of wisdom or encouragement can you leave with them watching this program right now on this proposed cuts?
Okay, thank you. What I would like to assure the patients is that, yes, there is a very formidable effort to cut down on the cost of dialysis. There are some terrible proposals like reuse of some of the consumables, which we are not going to accept or take lying down. But there is hope. For the last 3 years, we have been trying to meet NHIF. This crisis has brought us the opportunity to meet them. And the reason for that is that this is a decision they have made without any consultation. We do have a very robust constitution. We do have a very robust legal framework in the country and a pretty, very much independent judiciary. So any arbitrary decisions or actions that will affect any group of people, well, without due consideration on how they will suffer and without consulting them, we will not be taken down. We will not work in our current constitution. So we have the law and the constitution on our side. We are happy that NHIF has embraced dialogue. And for now, I would like to say, let us give dialogue a chance. The proposals have been shelved for 2 months. That's a step in the right direction for us. And we hope that in this period, we will be able to thrash out all the gray areas in this proposal and come up or arrive at a proposal that, or a settlement that everybody or every party will be comfortable with. So let us not be alarmed or agitated about this, and let us remain calm, and we will work out something. Thank you.
Awesome, thank you. And I agree with you, Mr. Kikonya, about the reuse of consumables, because here in the United States, back in maybe about 10, 15 years ago, they were using reuse here in the United States. I've been a renal nurse for about 36 years. And I can tell you days when they were using solution called formaldehyde to as a disinfectant, and a lot of mistakes can be made, especially if you're in a situation where you have people who have the same last name and may have the same first name or kind of exact name, and then if they on reuse, you can accidentally, if you're rushing, you can grab someone else's kidney instead of the correct kidney that's supposed to be hung up. So there's a lot of mistakes that can be made in reusing consumables. And here in the United States, when there were companies, I won't call any names, but there were companies that were using the filters up to 60 and 70 times. So if you can use a filter up to 60 times and still get reimbursed the same rate as you would if you throw it away, right there, you can see where that saves a lot of money and makes a lot of money for the organization. Moses, any last words you want to say to the people watching as being the kidney ambassador?
I'm sorry, before you go to Moses, let me ask if you have any literature on the reuse of filters in the US, please kindly share it with me.
Oh, absolutely. You send me your email address, Moses. If you can send me Mr. Kikoya's information through Messenger, I would get that information out to you, sir.
I've just sent it on the chat. No, you can pick it from there.
Oh, okay. Got it. Got it. Thank you. Moses, any last words?
We as renal patients, we also need to take center role in advocating for all these changes
I can't
that
hear
we
Moses.
wish to see. Can you hear me, Daktari and Steve?
Yes, I can hear you.
Okay. Now, we as renal patient, we need to take the center role and keep on pressing for these changes. We must not sit back. We must not joyride, but we must keep on pressing as patients so that the change we wish to see get realized.
That's it.
Yes.
All right. All right. Well, gentlemen, I'd like to thank Dr. Julius O'Kell, nephrologist at the Aga Khan Hospital in, is that Nairobi, Kenya, Dr. O'Kell? Okay, look like he froze up.
Kisumu, Kenya.
Okay, and
Kisumu,
I'd like
Kenya.
to also, okay, I also like to thank Mr. John Kikonya, president of the Renal Patient Society of Kenya. Sir, I hope we can get you back when this has gotten situated out so you can let us know what's happening with the task force. We would definitely appreciate that. And my co-host, Moses Kennedy, the ambassador, kidney ambassador. Man, this has been a great show, Moses. What do you think?
It is a great show. I'm glad, Gikonyo, you made it. I know it's been busy throughout the day, but thank you very much. Thank you. We expect you for another show one more time, if you allow us to plan one. Okay? To Dr. O'Kell, I'm also glad you made it to this interview. Thank you very much for the support you've given, especially me as an individual. You've always walked my journey. Thank you so much. Back to you, Steve.
All right, thank you, Moses. I don't think Mr. Kikonya heard you, but Mr. Kikonya, Moses just wanted to thank you for taking the time out and coming on the broadcast. He know your schedule was pretty busy today, so he's glad you joined, and he looks forward to you coming back and sharing with us what the task force has completed with the NHIF. So thank you, sir, for definitely coming on and doing everything you can to straighten out that technical difficulties that we had in the beginning. Thank you so much. And Moses, thank you, sir. I'll be talking with you soon. Dr. O'Kell, thank you again. And we look forward to hearing back from you guys on the situation in Kenya. Again, thank you for joining, and have a good evening, everyone.
Thank you. Thank you, and good night, everyone.
All right, good night. Guys, this has been an awesome show. We hope you learned something from this crisis that's happening in Kenya. If you didn't know, the NHIF, which is the main insurer in Kenya, is proposing drastic cuts. One of the cuts is for reimbursement of treatment from 9,500 shillings to 6,500 shillings. So that will mean a very drastic cut that can almost, as the kidney ambassador say, collapse the kidney program. Let me see if we have any more comments. Like to thank each and everyone who watched this show. Kip to Ronald, you're welcome. Elizabeth Osino, thank you. Jared Brown, host of the Warriors Quest, thank you for tuning in. We had Jonathan Trailer, host of Hope with Jonathan. Thank you for tuning in, sir. Uncle Jim Myers from Kidney Stories 2 chimed in. Chris Olia, and who else? Peterson, Oching, Ruth Millie. Thank you guys for watching. Also, I'd like to say, if you haven't read it, go to my website, www.stephenlbelcher.com, and pick up my book, How to Survive Outpatient Dialysis, a guide for patients with kidney failure. Again, that's available at www.stephenlbelcher.com. Great book if you're just starting outpatient hemodialysis. Very easy read, very simple, and very explainable. Again, you can pick this up on my website at stephenlbelcher.com. That's How to Survive Outpatient Hemodialysis, a guide for patients with kidney failure. Also available at Barnes & Nobles and Amazon. Guys, this has been an awesome show. Thank you for tuning in, and we look forward again to bringing back the kidney ambassador, Moses Kennedy, John Kikonya, president of the Renal Patient Society of Kenya, and Dr. Okel, nephrologist at the Aga Khan Hospital in Kenya. Thank you guys. Have a great evening, and we'll see you real soon. Take care, and God bless. Let me get the outro. Peace.
Warriors around, don't get caught in the mosh pit. Fuel to the fire, ain't nobody can stop it. Trouble in my city, but you know I'm across it. Got a 40 on my hip and I'm liable to spark it. Throw down these hits, my click is indivisible. I aim, you duck, I squeeze, now you invisible. I'm not afraid of getting physical. All these different chemicals are fogging up my visuals. Bloods on my hands, got slugs on my gunners. Yo, we notorious, we ain't no runners. Bloods on my hands, got slugs on my gunners. Yo, we some warriors, they ain't called gunners. Bloods on my hands, got slugs on my gunners. Bloods on my hands, got slugs on my gunners. Put on my sweat, put on the beat, put on the map, put on my team. Take out every motherfucker in between, know what I mean? Better myself, better my aim, better my rap, better my name. Killing rappers on my hang, I'm by their chains for the fame. Never thought I would it, now I'm running. You don't wanna follow me, now I'm fucking running.